get a chance to share my experience with all of you. I'm Chang Won from German University from Korea. Today my talk is 001 bifurcation reason. I'd like to start with a case. 72 years old gentleman was admitted for the typical angina, retrotracheal angiogram, and find out the posterior circumflex bifurcation reason. It's a non-true bifurcation as a Medina 001 and a very short segment. From our old experience, we regard it as a very simple reason. But is it really simple reason? Today is my question. So to understand the 001 bifurcation reason, we have to answer these four questions. First, how many 001 reasons are there? To answer this question, the instance of a 001 bifurcation reason is so rare. So to answer the first sentence, we have to make a big bifurcation registry data. So we collaborate with Korea and Italian group, and we merged the COVID-2, 3, and RAIN registry. It's more than 8,000 of bifurcation PCR registry. Then find out 001 is around 4%. It's a very rare situation. How about the prognosis of a 001 reason when we do the PCI? Previously, COVID-2 registry, not only COVID-2 registry, but all the history of a bifurcation PCI definitely showed when you compare the true bifurcation and non-true bifurcation, true bifurcation is higher MACE rate. Not only just MACE rate, but also cardiac death and MI is higher in the true bifurcation reason. But as we know that the 001 reason is regarded as a non-true bifurcation reason, so we theoretically we believe it's a benign picture. But when we review the extent characteristic data, as we know the true bifurcation is higher instance of MACE compared to non-true bifurcation reason. But when we select 001 reason, the MACE rate until 3 years was nearly 14% of MACE rate. It's the highest level. But as we mentioned that the COVID-2 registry is very old registry, including Christian and ES. So what about the risk data? So we changed the registry, exclude COVID-2 registry data, and then merge it to ultra registry data from the Italian group. So this registry include only secondary changes from 2010 to 2020. So among this 10 years experience, including more than 6,000 patients, still the instance of 001 reason was 4%. And the prognosis is same. 001 is the worst outcome. So previously we regard it as benign disease, but in real situation, it's not benign. It's at least not benign, but it's close to very malignant picture when you do the PCI. To understand the mechanism of 001 prognosis, we need to understand their unique feature compared to other bifurcation reasons. First thing is the clinical relevance of side branch. As a previous speaker commented about that, we believe that the PCI, revascularization rate, revascularization procedure is usually beneficial when the myocardial burden is more than 10%. But the previous our CT analysis showed that more than 10% myocardial burden in side branch is very rare, lesser than 20%. So the instance of clinical relevant side branch disease is rare in the real world practice. And second thing is overestimation of side branch disease, because genetically, OCR side branch has negative remodeling. So angiography looks significant, but the real situation is not so significant. So it is very difficult to find out appropriate indication for PCI for side branch disease. Not the same situation, but our experience about this, just a simple crossover, the left main, and then the circumflex artery, we saw that there is some anatomic and functional discrepancy was exist in those cases. And then when we measure the FFR in those regions, it's very clinically good indication for measure FFR and very good guidance for whether we treat or not. And then if the FFR was low, their prognosis is very poor with medical therapy. But if it looks like very jailed circumflex osteum, but the FFR is negative, their outcome is quite good with medical therapy. So FFR guidance might be applicable in 001 bifurcation reason treatment. Not only just negative remodeling, there are several limitations of angiographic assessment and the issue of PCI in those 001 reason. Not only negative remodeling, but also disease involved adjusted bifurcation segment, and the OCR classification of fiber optic path was frequently developed in the OCR side branch osteum. In the estimate of side branch reference diameter also important. In those cases, that anatomical and misclassification may lead to recoil, less acute gain, and inappropriate device sizing, incorrect landing zone, incomplete lesion coverage, unexpected main method involvement like a dissection. So how about this reason? As previously I showed that the OCR circumference, angiographic definitely 001, but if you apply the IBUS, definitely OCR circumference is a significant disease, but how about the proximal LAD? Not severe, but lumen is quite acceptable, but the crack burden is quite large, more than 50%. How about the dysalectomy? Surprisingly, and this looks normal in angiography, but I will show the significant calcified plaque in dysalectomy disease. So angiographic 001 reason, but it was underestimated. And if you apply IBUS 101 or at least 101 with two bifurcation reason. So if you apply just the angiogram, that is definitely a high risk of underestimation or overestimation of 001 bifurcation reason. So how can we treat this 001 bifurcation reason optimally? There are several ways to understand, but the most important thing is there are very prone to restenosis. I already mentioned there are unique feature as a negative remodeling, small diameter, and then high chance of underexpansion, and then low wall shear stress area can make a hyper development of neointima hyperplasia. So it is very high chance of stenosis. So when you review the EBC main trial, whether you use a 2 stent or 1 stent, 2/3 of restenosis developed OCR circumference reason. Even though you use just 1 stent provisionally, but just a simple crossover, or you finished with a kissing balloon technique, but still 1/3 of restenosis developed side branch osteum. So theoretically and fundamentally, most restenosis developed side branch osteum. So it is very prone to restenosis. So we have to be very careful when you decide side branch osteal treatment, whether you stent or not. When you review the previous experience, our experience about the stenting in 001 reason, so early 2000 we treat with 2 stent strategy, but nowadays we frequently approach with a provisional technique, just 1 stent. When you compare their outcome, compared to 1 stent or 2 stents, their outcome was not different. And whether 1 stent you do kissing balloon or not kissing balloon, 001 was no difference. So very high event rate, and then whether you put the 1 stent or 2 stent doing kissing or not, their outcome was poor compared to other bifurcation reason. And we also applied the circular analysis within aged and older or young patient, female, non-female, men, or diabetes or non-diabetes, left main, non-left main bifurcation. All the circular analysis do not different clinical outcome, whether you put the 1 stent or 2 stents. So it will be better to reduce the metal burden. So provisional strategy is highly recommended in 001 reason. And then we have to know that sometimes, as I already showed the circumference osteal disease, looks like I was angio 001, but I was 010. In those cases, we have to cross over stenting, and the stent design is so important because the left main part should be expanded largely balloon. And already Dr. Cho mentioned that the pop technique is so important. And the image guidance optimization also very important to get the better outcome. And the 1 stent strategy is sometimes, it looks like a very simple technique, but real situation is not so simple. just press OSTR stenting only applicable when the side branch angle is a wide angle. So 90%, 90 degree of a wide angle. In those cases, it's simple. One stent is quite acceptable to OSTR side branch. But in usual case, narrow angle, usually we have to cross over stenting. And then definitely POP is mandatory. But after POP, depends on the situation. Sometimes you need a kissing balloon technique. And then Jubo technique or flower technique, there are so many techniques. But in real situation, there are definitely many technical issues. Risk of geometric loss when you do the flush OCR stenting. And then sometimes stent protruding when you have a narrow angle 001 bifurcation reason. And the mechanical injury of main vessel. And plaque or carotid shifting sometimes is malignant. Even though it's carotid shifting, sometimes it make a significant jailing of main vessel. That's why nowadays we believe the DCB can roll in some part of 001 bifurcation reason. Strong point of DCB treatment in 001 bifurcation reason is a reduction in metal burden and free from the mechanical issue. And then preserving native coronary bifurcation anatomy and reduce the risk of thrombosis. But we have to know that there is a weak point because there is a highly elastic recoil of side ventral osteo and risk of coronary dissection sometimes to extend to main vessel. In those cases, we have two stent technique. And then most importantly, we don't have a large clinical data for DCB in 001 bifurcation reason. Fortunately, we have recently, it is not randomized study, but Professor Matthew trial, but we can compare the COVID-3 registry and then DCB registry in Korea and then make 250 patients and compare their outcome. Professor Matthew's trial. Fortunately, DCB is a better outcome compared to the DES, and then that was mostly related with the target reason revascularization. So at least we can apply DCB in the 001 bifurcation reason. And this is a representative case. OSTR diagonal branch is significant. And then their myocardial burden is more than 10% by CT analysis. And then if you apply the IBUS, main vessel is quite acceptable, and OSTR diagonal branch is tight jailed, and the FFR value was 0.63. And we tried the cutting balloon and applied DCB. And even though there is some dissection in OSTR diagonal branch, but FFR was quite acceptable, and then we finished with procedure DCB for 001 reason. How about this previous OSTR circumference disease? Actually, we mentioned the distal left main disease, so I have to crossover stenting from the proximal surge to left main. But you can easily detect there are some carotid shifting for the RAD, and we measured FFR for RAD, and FFR was 0.8 or 0.78. So it's a functionally similar to jailed RAD, so I have to finish with a pure stenting. So 001 is not benign, and technically is sometimes we have to wear out stenting for the complex procedure. So this is some summary step of how to manage the 001 bifurcation. First, we have to remember, is it clinically relevant diagnosis or not? If it is not clinically relevant, just medical set, leave it alone will be enough. If it is really significant, clinically significant large size range, then you have to confirm because it's a high chance of negative remodeling. FFR negative, just medical. If FFR positive, in those cases, you have to confirm with the intravascular injury whether it is really 001 reason or is really complex bifurcation reason. If there is a really 001 reason, in those cases, you can select from main vessel disease or the left main vessel disease. If side branch ostium is not so complex, just the plan modification and the DCD approach is highly recommended, and then provisional one stent technique also acceptable. If left main bifurcation, it means OCR circumference situation. Usually I prefer the provisional one stent strategy, but you can select DCB treatment. So this is my summary slide. There are limited evidence regarding the optimal treatment strategy for Medina 001 bifurcation reason because it's a uniqueness and the rarity of such reasons. So it's usually lesser than 5% of all bifurcation reason. And recently, there has been a tendency for provisional strategy, The angiographic 001 bifurcation is not always 001 lesion, so additional intravascular imaging or physiology will be very helpful to understand this situation. And the clinical outcome of PCI of 001 lesion appears unfavorable. Therefore, we have to take a higher risk than our thought. So you have to remember it's very complex and malignant. So it is imperative to consider a variety of treatment modalities, including DCB, when deciding the most appropriate approach for each 001 application. Thank you very much for your kind attention.